So good morning and namaste to all the members of the Radiology Society of Thailand. Before I go into my lecture for the next 30 minutes, let me thank Professor Napapang and Professor Ang Tuan Hung, the chair of the ASIASAFE of the Asian Oceanian Society of Radiology, and who has given me this opportunity to share the MR safety practices in the Asia-Oceanian region and the ways to improve that. As the lead for MR safety in the Quality Safety and Standards Committee of Asian Oceanian Society of Radiology, we have been conducting several webinars and have conducted a survey on to understand the basic practices that we follow in the Asia-Oceanian region as we have different socioeconomic conditions in different countries of the 52 Asian nations. For the next 30 minutes, I'll be talking to you on the safety aspects in MR practice. This is a very profound statement by one of the visionaries of the 20th century, Dr. R. Buckminster Fuller. Since the initial publication of the chart of electromagnetic spectrum, humans have learned that what they can touch, smell, see, and hear is less than 1/1,000,000th of the reality. 99% of all that is going to affect our tomorrows is being developed by humans using instruments and working in ranges of reality that are non-humanly sensible. Non-humanly sensible, especially with the eyes that you cannot see some of these things, that is what they hold most of the major components of electromagnetic spectrum. And he also made a very interesting comment that why a popular mind cannot understand science and find it difficult to get into the mathematical principles and physical principles to understand the nature and science. So he said popular mind has got a difficulty there. And that exactly is the reason why a modality like MRI, which uses magnetic field and radio frequency wave, is not easily comprehensible to the common man and also even to all the personnels involved in the practice of MRI. So MR safety is basically equivalent to a patient safety. That patient safety is of utmost importance. MRI, which provides the opportunities for exceptional soft tissue contrast and non-ionizing radiation exposure, is increasingly used in healthcare diagnostics. Advances in MRI technology and the application of these technologies for different clinical conditions often lead to the identification of new safety issues. The three magnetic fields in MRI, what I'm talking here is about the MR environment. The three magnetic fields in MRI, the static magnetic field, time-varying magnetic field, and the radio frequency field, that can lead to different safety risks. And the adverse events associated with exposure to these electromagnetic fields may include vertigo, nausea, hazards caused by projectile forces, biomedical implants, and the device risk, the translational forces on ferromagnetic objects, and the peripheral nerve stimulation, heat deposition, and acoustic noise. So there are a lot of issues that can be related to MR in practice. So is MR safety a hype or a real issue that we need to be really concerned about? there has been fatal accidents in MRI. In 2001, 6-year-old Michael Colombini died by hitting the oxygen cylinder that came as a projectile and hitting a skull when he was being scanned for postoperatively for a brain tumor in an MRI gantry. In 2018, in Mumbai, there was another incident where a ward boy accidentally rushed into the MRI gantry, MRI unit, with a oxygen cylinder when he heard the emergency. When he heard about an emergency call, that he rushed into the MRI room and got accidentally stuck and he died. And more recently, much more recently, in 2021, in October 18, there was another fatal accident which killed a elderly individual in South Korea. So there has been several fatal accidents related to MR, related to MR. But apart from these projectiles, there has been several incidents of burns due to MRI, and there has been so many other near misses. If you speak to anyone in any MR department, they've got a lot of stories to say on the several different kind of MR accidents that has happened. So MR safety is a real issue that we need to be concerned about, especially in a setting where there are more and more MR units being installed all over the world, especially in the Asia-Oceanian region. There have been installations of MRI are increasing. The strengths of magnet used are also increasing. So there are definitely concerns and issues related to MR safety that we have to address. That is why the AOSR, the QSS committee, the Quality Safety and Standards Committee, and ASIASAFE is making a lot of effort to create this awareness and to put the MR safety practices in your institutions. In every institute, in a hospital, there are several areas of restricted entry, maybe a theater complex, surgical theater complex, or an ICU, and even the X-rays and CT scans. We have got different warning signals there, and it is essential to have these kind of restricted entry and warning signs in the MRI zones in the MR system. So also, wherever we practice MRI, we need to have this kind of a zoning to have the restricted entry and warning signs. So unfortunately, MRI is being projected as a very safe modality. Generally, even amongst the doctors, non-radiologist doctors and other hospital staff, there is a feeling that they can easily get into the MR room without much supervision, without much screening. So these sort of myths, these sort of wrong notions has to be clearly sorted out, and the restricted entry and warning signs has to be put in front of your MR installations. So to create this awareness and as part of this campaign, ASIASAFE and AOSR conducted several webinars, and 3 webinars that were conducted. And the first one was in December 5th. On December 5th, the topic was, what lessons have you learned from MR accidents? The speakers were Mathew from Philippines and Dr. Anirudh Kohli, who is editor-in-chief of Indian Journal of Radiology Major. And in the second webinar on 16th of January, we discussed about implementing pragmatic MR safety in a healthcare facility. 2 ambassadors of MR safety from the Asia-Oceanian region, Dr. James Hallinan from National University Hospital in Singapore, and Dr. Elaine Khan from the Hong Kong Children's Hospital, talked about implementing pragmatic MR safety in a healthcare facility. I'm happy to note that Dr. Elaine Khan will be giving the next presentation here for the Radiology Society of Thailand in this session. And in the third webinar on 20th of February, we had the industry players and their role of MR safety was discussed. The major players from GE, Siemens, and Philips, they discussed various aspects from the industry perspective, and that how is industry collaborating with the end users, what aspirations what we can expect in the future from each vendor in terms of technology advancements with respect to MR safety, and what can or they are doing to assist users to help MR accidents, and how can they involve in the MR training processes. So these were the topics that we discussed, and I'm happy to share some of the screenshots of the webinars, and it was open and free to the members of the Asia-Oceanian region, and I'm sure some of the members of who are attending today must have attended these sessions earlier. Apart from this webinars, we conducted an AOSR MR safety survey as part of the QSS initiative. And the survey elicited, we asked several questions to the respondents, and the survey elicited 59 responses from 18 countries and included responses from national radiology societies and individual respondents from some countries. None of the respondent countries reported the presence of national legislation on MRI and MR safety, and most countries, 90%, did not have documented National Radiology Society guidelines on MR safety. There were 18 respondents, 18 countries that responded to this, India, Taiwan, and thanks to Thailand, there were 4 respondents from Thailand, Singapore, Malaysia, Philippines, Republic of Korea, Bangladesh, Vietnam, Sri Lanka, Republic of China, Qatar, Pakistan, Oman, Japan, Indonesia, Fiji, and Australia. And these are the countries that responded. 79.66% of the respondents reported that MR safety guidelines were available at the institutional or the hospital level. 93% responded that reported the availability of MR safety guidelines at the radiology department level. And most radiology departments use a checklist or protocol for pre-MRI assessments, 93.2%. These are some of the inferences that we had. I am sharing it here with you from the AOSR MR safety survey. 84.75% of the respondents reported that there was site restriction or zoning for their MR services. But if you honestly look into the Asia-Oceanian region and the different countries, that mainly the tertiary centers might have responded to this survey. That's what my inference is. If you look at the centers from the secondary surveys, secondary levels of healthcare, many zones, many places do not have the zoning. Especially the zone 3 is absent in many of these places. This is one of the basic requirements that we need to implement. 43 respondents, or the 72.88% respondents, reported the availability of a list of MR safe items at the departmental level and the provision of this list to patients before MR imaging. 51 respondents, or that is 86% of respondents, reported that there was regular screening of MR staff. However, screening of non-MRI personnel was reported by only 57%. So there is a huge requirement to give training or orientation program for non-MRI personnel within the hospital to avoid MR accidents in the future, especially during the off hours when there were the restricted entry or the personnel to supervise are less, or there is a relative laxity in the whole system. AOSR MR safety survey also revealed 85.29% of the respondent units was screening of non-MRI personnel was done, reported using ferromagnetic detectors. So this is one question that we asked, are you using ferromagnetic detectors for screening? And most of the 85% centers responded positively. But then again, most of the centers that participated in the survey were tertiary centers or well-equipped centers. And if you honestly look into the secondary level centers, we do not see the use of ferromagnetic detectors at a large scale. Only 71% of respondents reported that they screened the persons accompanying the patient for MRI, and 75% of these respondents reported using ferromagnetic detectors for screening. And another question was on the MR safety training for staff at respondent radiology department. Once in a year for 31.6%, all new staff undergo training in 36.67%, and there is no training in nearly 20%, once in every year for 6.67%, and twice a year or more than twice a year for 3.3 and 1.6%. So there is a huge requirement here for training programs on a frequent basis. MR safety training for medical staff outside the radiology department. This is a very important slide. 55% do not have any kind of MR safety training or orientation for medical staff outside the radiology department. And we asked one of the question that we asked was about the MR safety incident reporting system that the hospitals, that the institutions had. The answer was 56.67% did not have. 67.67% did not have an MR safety incident reporting system. So this is very, very important. The incident reporting system, the reporting of critical incidents is important from the perspective of magnitude and provides a good learning opportunity to further improve of refined safety standards and processes. Critical incident reporting system exists, but they are grossly underutilized. Kilberg et al. Reported only 38% of the critical incidents were reported, and that several of the unreported incidents could have turned catastrophic. That is what, when we discuss with any radiologists in an MR installations, they will all have a story to tell about the near misses. So these are the unreported incidents that could have turned catastrophic. A major finding from their study was that only half of the study sites had implemented the EU directives of MR safety. Hansen et al. Observed that 16% of MR safety incidents had the highest severity or worst case scenario score. That severe adverse events still exist. Despite safety protocols, critical incidents are poorly shared with the team and are preventable. Hansen et al. Reported that the confidence in the internal communication or local reporting systems might be much greater than the true usefulness of such routines, and there is a need for careful design of critical incident reporting systems to facilitate use and sharing of information. Blankholm and Hansen have also reported from a high rate of underreporting of MR safety incidents, with 53% of MR professionals reporting involvement in an MR-related incident that was reported, and 25% reporting involvement that was not reported. So now coming back to our MR safety, so I will just explain the webinar to create about awareness and also about the details that we got from the MR safety survey that we conducted in the Asia-Oceanian region. But now coming to MR patient safety within the context of MR imaging, there are three vital factors that we need to consider. One is a human factor. That include the patients, attendance of family members, and the healthcare service providers. The second is instrumentation and technology used for the imaging that include the magnetic fields and the various accessories that are required. The third is the external environment and the robustness of the systems and the processes used to identify, report, and avoid critical incidents. That includes the standard operating protocols, the policy, and the audit and the feedback that systems that we need to create. And the human factors, it is essential to have the training and to assign responsibility and to promote effective communications within the department, within the team members, outside the department, to the patients, within the hospital. So there needs to have effective communications that's to be promoted. The risk communication strategy as risk communication has to be promoted. And in coming to the instrumentation and technologies, the systems, mainly the MR environment, that we need to understand about, and the restricted entry, the design of the system, and the industry's involvement in improving the MR safety in terms of technology. So all these things comes under that. So I'm very happy here to propose a concept that I would like to promote as part of MR safety, especially in our Asia-Oceanian, in the Asia-Oceanian region. As a part of this AOSR-ASIASAFE initiative, I'm proposing a MR safety pyramid. This is a MR safety pyramid that we need to promote and build in every department with the triangle of the sides of this, the base and sides of this triangle are formed by the mission and the team and the leadership. The rungs or the steps of this triangle, of this pyramid, are formed by 4 steps to MR safety, which is at the apex. To reach the MR safety, we have to have this training and assignment of responsibility, communication or effective communication, within the system, outside and outside the system. And the systems are the MR environment, and the protocols or the processes, that is the standard operating processes or protocols which related to special situations, in related to MR screening, in relation related to implants, devices, and projects, implants, devices, and objects. So we need to have these are the this MR safety pyramid is something that I would like to promote as part of MR safety in our region. I'll go into the details of each and every part of this MR safety pyramid that you need to build in your department, in your hospital. The mission forms the base of the pyramid, and that mission has got two components: to promote MR safety practices and to reduce MR accidents. This is the first mission. The second part of the mission is to increase MR safety consciousness and promote just culture for patient safety. And who constitutes the team? It's the MR medical director, MR safety officers, and level 1 and level 2 MR personnels, because they are the people who are manning in the MR installations. Then the leadership. Leadership is a much more bigger canvas of visionary people or the people who have got expertise to guide the team. They have got the MR safety committee at the institutional level, which should have the management representatives, other non-radiology doctors. The MRMD from the team of MR also has to be part of it. And at a larger scale, at the state or provincial level and at the national level, there has to be the MR Safety Council or MR Safety Boards, where the National and State Radiology Association and the Regional Association representatives from Asia-Oceania Society and the Health Ministry or the legal authorities, or everyone has to be made members or made aware of this concept and of MR safety. So this is the broad structure of the MR safety pyramid. Now we will go on to the different steps to that MR safety pyramid. This is the base of the first and foremost important one is the training and responsibility. You have to have the training for the MR personnel and assignment of responsibility, and because they are the people who are going to make a difference to your installations, because they are the people who are constantly watching that, training them, giving the audit, doing the root cause analysis, and they're the assigning the responsibility is very, very important. The second part is communication, and third, as I've also already mentioned, this focuses on the systems, including the MR environment, processes or standard operating protocols. And these are the 4 steps to MR safety. So the 4 steps to MR safety, the first is training and assigning responsibility. The responsibility of the MR medical director, MRMD, is to conduct training programs at regular intervals at institution for MRSOs, MR safety officers, level 2 and level 1 MR personnel, and for all hospital employees and management. MRMD and MRSO training modules and competency certification is a priority that AOSR and is giving right now, and also exhort the national societies to take forward this initiative to have the training modules and competency certification for MR, MD, and MRSO, the medical directors and the safety officers. The personnel, the definitions, who is a non-MRI personnel? The patients, visitors, or facility staff who do not meet criteria of level 1 or level 2 MR personnel. Who is a level 1 MR personnel? Those are individuals who have successfully passed safety educational efforts as defined by MRMD, sufficient to ensure their own safety and that they do not pose a potential threat to themselves or others as they work within Zone 3. Level 2 MR personnel are individuals who have been more extensively trained and educated in the broader aspects of MR safety, including but not limited to RF safety, dB by DT related safety of time varying, imaging gradients, cryogen safety, contrast agent safety, etc. So these are the MRI technologists, radiologists, radiology department nursing staff, etc. The organizational structure or the team leaders for the MR safety pyramid are MRMD, the MR medical director, usually a radiologist, assumes overall and ultimate responsibility for MR's facility operational safety. Safe execution of all MR examination is his aim. He has to appoint the MRSO and MRSC, the MR safety experts, usually MR physicists, and development, implementation and maintenance of specific policies and procedures pertaining to the safe operation of MR services, the development of an appropriate system for record keeping and analysis of adverse events. And what are the responsibilities of an MRSO, MR safety officer? It's usually an MR technologist. There can be one or more MRSOs in your institution. They have to ensure that proper policies and SOPs, standard operating protocols, are implemented and enforced on an ongoing basis. And they have to ensure that the adequate written safety procedures, emergency procedures, and opening instructions are issued. Providing safety advice on the modification of MR protocols in cooperation with MRMD and MRSC. Now, the second step towards MR safety is communication. I'm going to give a very high importance, very high level of importance to promote communication, importance of communication within your system, within the department, within the hospital, with the patients, with the industry, with the health authorities. Communication is the key. MR safety communications include the MR screening, gowning, final checklist, and you can even use creativity to have an app-based or a video or animation-based education materials, use of social media. I would recommend each one of you to unleash your creativity for the most effective communication that is possible within your department. MR screening is the staff and the personal screening has to be done, the patient screening, conscious, non-emergent patients, the special patient population screening, non-ambulatory patients, pediatric patient, physiologic monitoring during MR studies, and on the communications on implants, devices, and objects. So all these are part of the communication. So there are lots and lots of communication, importance of communication for MR safety, to create awareness and as part of the screening procedures. The third step to MR safety is systems or the MR environment. Adverse events associated with the static magnetic fields include interactions with human tissue and with equipment projectiles, implant malfunction or movement, malfunction or movement of monitoring devices. So the risks are associated with radio frequency include the specific absorption rate issues, tissue heating, burns, implant heating, and implant interference effects. Major risks with time-varying gradients of peripheral nerve stimulation and acoustic noise, including potential interference with implants and monitoring devices. In an MR environment, you have to implement the concept of zoning. The MR functional diagram will be like this. There are 4 different zones. Zone 1 is a safety zone where even public can enter. Zone 2 is after patient screening with the ferromagnetic detectors. It is where you have the patient preparation and safety. And the zone 3 is a restricted entry zone. Only an level 2 MR personnel can give access to the patient or the bystander to the safety zone 3. And safety zone 4, the MR zone 4 is where the equipment is. That is the highly restricted area. So this zoning is very much essential in our MR safety practice. Another concept that has to be implemented in a very perfect sense is MR safe, MR unsafe, and MR conditional. The FDA labeling criteria developed by the ASTM International for portable objects taken into zone 4 is MR, the green rectangle, the green square is MR safe. They are usually non-metallic items. MR unsafe, the red round one, is MR unsafe. It's has got metallic component, can become a projectile and can cause severe MR accidents. And MR conditioning, the triangle indicates that the object or device may be safely used in the MR environment, provided the conditions for safe use are met. Decisions based on published MR conditional or safety claims should recognize that all such claims apply to specifically tested static field and spatial field strengths and only apply to precise model, make, and identification of the tested object. So this is the broader concept of MR safe, MR unsafe, and MR conditional. MR conditional is an ever evolving process, especially with the strength of magnets and the kind of equipment, accessories that we use So the MR conditional is something that needs to be deliberated seriously by the MR technologies and radiologists. And the fourth step to MR safety, if you have to reach the apex of MR safety, the fourth step is the protocols or the SOPs and the audits, the standard operating procedures, specifically in areas like implant devices, objects, MRI contrast agents, MRI patient risk assessment, physiologic monitoring during MR studies, pregnancy, patient pregnancy, and healthcare practitioner pregnancy. There has to be specific protocols for in all these situations: unconscious, unresponsive, altered level consciousness patients, pediatric patients. I'm sure Dr. Elaine Khan, who's working in a pediatric hospital, will enlighten our delegates on the various SOPs that they use in the pediatric patients. The claustrophobia, anxiety, and sedation patients, and the prisoners or detainees. What are the SOPs for them? Emergency responses and the management protocols has to be designed and trained, and the team must be trained on that. Special consideration for RF radiofrequency thermal issues to prevent burns, especially in patients with skin staples, patients with tattoos, drug delivery patches and pads, and electrically conductive clothing, which is increasingly being used. But essentially, we have to have the gowning from the MR department itself, and that will eliminate some of these issues. So, MR safety, what are the priorities in working to build the MR safety pyramid in your institution? Identification and demarcation of specific risk zones. These are some areas that we have realized that many centers, many institutions do not have. So the zoning is essential, especially the implementation, the demarcation of zone 3, which is lacking. Many places it is the zone 2 and 3 are mixed together. So it's time for us to think seriously to alter the design and for all new installations to essentially include all the 4 zones. And wherever the space restrictions are there, there has to be some kind of a mechanism, some kind of a design that has to include the zone 3. Design of specific educational programs dedicated to every category of professionals that work in or might visit MR sites at regular intervals. This is a very important focus that AOSR right now is going to give, where they will be having modules and specific training programs and certification programs for MRMDs and MRSOs. And I'm sure this, as I already mentioned in the MR safety pyramid, the training and assigning responsibility is a very, very important step. So we have to give a lot of importance to this particular aspect. Another aspect is development of state clear MR safety procedures, including screening forms and protocols. And finally, one of the priority that we have to give is rigorous but easily manageable incident reporting systems with focus on prevention and learning from mistakes. And a concept that our president of Asia Oceania Society of Radiology, Dr. Evelyn Ho, wants to promote in our region is to have a just culture within your institution. So it is humans can err, but we have to create a just culture where we can reduce the errors and minimize the errors without having a blame game or a blame culture, but having a just culture, and to have the incident reporting system from which we can learn and improve the situation. So again, I'm emphasizing on this proposal that I'm giving here on MR safety. This is the MR safety pyramid that you need to build in your department. With that message, and hope that all of you will make a sincere effort to build an MR safety pyramid that is proposed by AOSR and ASIASAFE to have an MR safety pyramid in your department with this ways and sides of this pyramid and the 4 steps to MR safety being implemented. Thank you very much for a patient listening. Thank you.